So I'm Robert Benz. I'm a spine surgeon here at the Orthopaedics Center, and I have a partner, Bill Biggs, the two of us that do spine. So today I'm going to talk to you about the evaluation and treatment of cervical myelopathy. It's not quite as sexy or as exciting as Arturo's comment about blood, but here we go. I have a disclosure, but I'm not talking about anything. So this is an example of a lady that came in to see us. She was a 74-year-old, referred for back and leg pain, kind of had the classic symptoms of neurogenic claudication with limited walking ability. But on her history, she noted that she was having some issues with balance. And usually when you have spinal stenosis like that, it doesn't necessarily cause balance problems. Here's her x-rays. It shows she has a degenerative scoliosis, a little bit of a spondy there. But when we examined her, I had her do the classic, tandem gait, and she was falling all over the place. We checked her reflexes, and she was very hyperreflexic. Hoffman's sign, I'll show you a video of that in a second, and she had normal strength. But because of her neck, we were worried about that, so I took x-rays there in the office, and if you guys, sorry I can't point to both screens, but she has a pretty good spinal cord compression there up at C3-4, and on her x-rays, a little bit of a slip there at 3-4. A lot of trees in this auditorium, it's hard to see. And then her spinal cord is getting compressed pretty severely up there at 3-4. So the last thing we want to do is take that lady to the operating room, flip her over on her belly when she's off to sleep, and then ding her spinal cord more. So in her case, we went in from the front, did her neck first, went in and did an anterior cervical discectomy infusion on her, and then a couple months later, we did her back. In her case, actually, we did an MRI, and I didn't have her cord quite as decompressed as I would like, and we ended up doing a laminectomy from the back of her neck. So here's my plan for the day. Whether or not I'm like Ted Lasso here and follow the plan, we'll see, but we'll kind of define what myelopathy is, review the anatomy, look at the various causes, go through the diagnosis and workup, and then talk about operative and non-operative treatment. So a quick Greek lesson. So the word myelo comes from the Greek word myelos, which means of the spinal cord. Opathy is a disease or a disorder, so it's a disease or disorder of the spinal cord. Quite frequently, you'll hear or look in the MRI report, you'll see the term myelomalacia, which basically just means softening or loss of volume of the cord. And then gliosis is more of like scar tissue formation in the cord. So what's the difference between myelopathy and radiculopathy? So myelopathy is pressure on the spinal cord that leads to spinal cord dysfunction. Radiculopathy is more just a pressure on the individual nerve root, which then usually leads to pain, numbness, or weakness in that specific nerve distribution. And today we're talking mostly about the myelopathy. A quick review of spinal cord, in case any of you guys need a quick nap. But basically, the gray matter is kind of where the processing occurs. The white matter is those myelinated fibers, which is more the communication up and down the spinal cord. So the sensory fibers come in from the back, motor fibers go out the front. And if you really want to get in the weeds, look back at your neuroanatomy classes that we took and mostly forgot. But you have the descending motor tracts, the ascending sensory tracts. And the important part for this is that in the spinal cord anatomy, those upper arm functions is more centrally located. And so if you get a central cord syndrome, the upper extremities are going to be affected more than the lower extremities. And here's some pathologic slides. So on that normal looking cord, you can see the gray and white matter nice distinction there versus a cord that's been compressed. And so we start off with micro trauma, a little bit of narrowing starts to slowly ding on that cord. You can start to get cellular damage, cellular death, and then this distinction between the myelinated fibers and the gray matter starts to go away. If it gets bad enough, you can actually get cyst formation, cavitation in the cord, and once that happens, it's completely irreversible. The causes, today we're going to spend most of our time talking about cervical spondylitic myelopathy, and that's just basically arthritis in your neck. A combination of those things starts to cause pressure on the cord. There are other causes, including congenital narrowing of the canal. There's a condition called OPLL, ossification of the posterior longitudinal ligament, and we'll spend a little time talking about that. And there's more rare cases that we're not going to get in today, including things like tumor, abscess, trauma. This is just a side view of the cervical spine. And so the compression can occur from the front or the back, or commonly from a combination. So on the front side, you have things like disc herniations, and it's pretty rare that acute disc herniation will cause myelopathy, but it can. A lot of the folks get osteophytes that form off the back of the vertebra that can compress on it. And then that ligament that runs along the back of the vertebra, the posterior and longitudinal ligament, there are cases where that can get calcified, and I'll show you another couple slides on that. On the back side, the ligamentum flavum can get infolded, or you can also rarely get facet cysts in the cervical spine. Some people will get instability where the vertebrae are shifting around, moving around too much relative to each other, and that can compress on the cord. And there was a study that showed like about almost 2/3 of people who develop myelopathy have a congenitally narrowed canal. Quick word about OPLL. So this is a gentleman we saw in the office. Came in, was in a wheelchair, but you can see down there, I think that's at 6'7". He's got just that calcium buildup along that the posterior and longitudinal ligament. This is more of a common problem in people with Asian descent. It's up to quite a bit higher, up like 4.5%. And the actual cause of why that forms is unknown. Here's an example of someone who has pretty severe instability in the neck. And we'll see a lot of people who get disc degeneration at C5, 6, and 6, 7, like when they're in their 40s, it seems like. And those kind of collapse down, but then as they age, it's almost like having a fusion at those lower levels where the upper ones will become more unstable. So she required a fusion. And the true incidence of myelopathy is unknown. There's a lot of people who have narrowing of the spinal canal if you do like an MRI study, but only a small number will actually develop symptoms. But bottom line, as you can see from that graph, it's generally more of a problem in males and more of a problem as we age. There's numbers down at the bottom as far as it's a higher incidence in the Asian population. So how do these folks present? I mean, they complained of neck pain and neck stiffness, but most of us above 50 have that anyway, so that's not very specific. But you got to look at their neurologic symptoms, and sometimes they don't really say, well, I'm just getting older, I have my balance, I attribute it to just being old. But if you check things, ask them, can they do the heel-to-toe walk? Ask them about handwriting, button-in buttons. Those are things that can subtly come on. If it gets bad enough, they'll have some rather just diffuse numbness in their hands, and if it gets really bad, then they'll even have problems walking. So physical exam, simple things like checking the range of motion, doing the flexion extension, see if it produces any of the Lee-Hermites, like lightning strike sensations. I don't see that very often, but occasionally. Do the tandem gait, heel-to-toe walk. You can do the Romberg sign where you have them close their eyes and see if they can maintain their balance. Their shoes are off so they can have some proprioception. Check their reflexes. And if they do have nerve root compression, sometimes their upper extremity reflexes aren't all that impressive. If you check their knees, usually it's pretty profound. Hoffman's reflex, I'll show you a video of that in a second, inverted radial reflex. And then Babinski, I don't do that much. I mean, it can. I think a lot of times it's pretty equivocal. So if you want to show that inverted radial reflex there, so you're basically just holding the arm, tapping that. You can see those fingers will flick together. And then the other one's not the Dr. Benz hand reflex, but it should be called the Hoffman's reflex. So if you can play that one on the other side. So you just have them relax as much as you can. You can flick that long finger. You can kind of see the thumb and first finger flicking together. And that's not like a pathognomonic for myelopathy. As you can see the sensitivity and specificity rates, but you put that in combination with the other things that can give you an idea. Another one is to do the 15-second grip and release. So a normal person should be able to do that at least 25 to 30 times. If it's substantially lower, it's a sign that that cord isn't working right. X-rays, so usually we start off checking X-rays. People used to put more emphasis on that Torg-Pavlov ratio, so it's the width of the vertebral body versus the width of the canal, but it doesn't really correlate very well with spinal canal diameter. You want to look at their alignment, whether or not their spine is bent forward, kyphotic, or if they have the normal lordosis. And then if there's any signs of any subluxation, I'll usually check a flexion extension view just to see if that's moving around excessively like that patient I showed you previously. The MRI is kind of our workhorse for making this diagnosis. So this is if you can see there, you got the bright spot there in the cord, so that increased signal on T2, and you also note that there's a complete loss of the CSF signal around the cord. And then there's some studies, which I rarely see this, but if you look at the T1 images, and there's signal dropout, and they're high signal on T2, that's just a bad sign that they're going to get any recovery with surgery. If you can't get an MRI, they have a pacer or something like that, but thank goodness a lot of pacemakers are MRI compatible now, so it's becoming less of an issue, but we'll get a CT scan or a CT myelogram. And I find it's very helpful just to get a CT scan on almost all these patients, just because we've been fooled once or twice, and you don't want to have that happen, but you think it's a soft disc, you can see on that MRI, but then you get the CT scan, which you think is disc is just calcified OPLL in there, and that's that cross-section down in the section. You can see how much of his canal is being disrupted with that bone spur, or the OPLL, I'm sorry. So surgical versus non-surgical. So first thing I would say is if people have myelopathy, they have problems with reflexes, coordination and such, there's really no non-operative treatment that's going to stop that or reverse it. That's the problem. But there's a lot of folks who come in who have pretty bad stenosis, who are not symptomatic, and so the question we're often asked is, am I going to get worse? That number there, 20 to 60%, that's really not all that helpful. That's a pretty big range. It's like, yes, maybe, no. So it's really unknown. But once we have that diagnosis, like I said, we typically would recommend surgery if they're a reasonable operative candidate. So if they're very elderly, if they have really poor baseline functions, or morbidly obese, have diabetes, terrible heart disease, then we might not recommend putting them through the risk of surgery. As far as that risk of progression, and it's something that's been studied, but there's not really a lot of great studies on it. This was a study out of Taiwan where they looked at a national database, and a lot of those patients had the ossification of the posterior and longitudinal ligament, and you can see the numbers. So the top line there is OPLL that were treated non-operatively, and then over the next 15 years, about 4.1 out of 1,000 patients developed a spinal cord injury. The folks who had surgery were a little bit better. The folks who did not have OPL or didn't have surgery were still better than the OPL group. But surgery seemed to help out both of those. So the conclusions that if you're a man with OPLL, you generally have worse outcomes, but surgery overall decreases the risk of spinal cord injury over the ensuing years, and there's some limitations of that study. It's always disappointing when you see a meta-analysis that has 5 studies in it, just a sign that it's something that's a hard problem to study, but they tried to sort out. They had patients who had spinal cord compression, and then trying to figure out who was going to develop symptoms over the ensuing years. And so the risk overall seemed like it was about 8% at 1 year. Roughly 1 in 4 people will develop increased symptoms within 4 years. And they looked at risk factors. If they had weakness when they presented, like a radiculopathy, that was a poor prognostic indicator. I really couldn't understand why the lack of T2 signal made any difference, but they didn't really explain it in the article, but that was a risk factor. And then you might consider sending someone for an EMG if they have like a prolonged motor evoked potential or somatosensory evoked potential. That's a poor prognostic indicator. And then another question we see all the time where patients come in with an MRI, their spinal canal's narrowed, and they were advised to have surgery because they said, if I don't have surgeon told me if I don't have surgery, I'm going to be paralyzed if I fall off a ladder. It's a tough thing to study. There was a study out of Europe. They had about 200 patients who they had identified that had cord compression. They weren't myelopathic, and then they tried to follow them. And there was only found 14 traumatic episodes, but bottom line, there was no significant association between those episodes and developing spinal cord injury. These patients hadn't been advised to avoid high-risk activities. So what do I do besides crash my mountain bike? That's not me. So if patients come in and they're symptomatic, they have balance problems, they have numbness, we see their MRI shows their cords getting compressed, we generally advise those folks to have an operation to prevent it from getting worse. And if you catch it early, a lot of times people will get some regain of function and a decrease in the numbness. Asymptomatic patients, it's basically counseling them to be a little careful with their activities. and you might consider seeing them back in the office more frequently. There's really no good data that you should re-scan them, but if you see them back and it seems like their exam is a little different than it was the first time, you might want to get another MRI. Non-operative treatment for those patients who aren't surgical candidates. Certainly you can have them work with therapy on gait and balance training, OT, doing activity modifications, and then tell them not to be Clark Griswold, stay off the ladder, don't hang up your own Christmas lights. If they do have increased symptoms, then probably want to come back and see us. So surgery, that's going to spend a little time going through some cases here. Bottom line, it comes to, do we want to come from the front of the neck or coming from the back of the neck or do both? Coming in from the front side, just complications. Most folks will have difficulty swallowing. That's kind of our biggest issue with that. And that's a combination of us retracting the esophagus out of the way and keeping it retracted for a period of hours while we're doing the surgery. And also we generally really lengthen that spinal column. That can cause some stretch to the esophagus that can affect it. Other options come from the back include doing something called a laminaplasty that I'll go over, and then a laminectomy infusion, and then sometimes we need to do both a front and a back. I guess like Willie Sutton said, you go where the money is. Basically, we go where the compression is. If they have a disc herniation, we generally can get to that better from the front side. The only exception is folks who have OPLL, that calcified ligament gets really scarred down to the dura, and so you have a high risk of getting a dural tear when we come in from the front. So if you see that, we really want to stay away from it from the front side. Other things we look at is their alignment. So if their neck is bent forward, if we come in from the back and do a laminectomy, that spinal cord really isn't going to move away, and I'll show you a slide of this thing called a K-line. And if their neck is unstable, then we'd probably need to do some type of a fusion. So on the MRI scans, it's not something that you're going to spend a lot of time looking at, just kind of the concept. But the slide there, I guess that's on your guys' left side. You draw a line between the center of the cord at C2 and then down to C7. And if most of that compression is a few millimeters in front of that line, then if you take off the lamina off the back, that spinal cord should be able to drift posterior a little bit and free it up. Versus if their neck is kyphotic and you do a laminectomy, the spinal cord isn't going to get decompressed adequately. So from the front, we can take the disc out. Sometimes we can do a disc replacement. That's not very common for this population, but occasionally. Most time it's going to be a fusion, and sometimes we need to take out actually a portion of the vertebral body called a corpectomy and do a fusion. So here's one of the few cases where we've found that a disc replacement would be an option. This is a 34-year-old lady come in with the biggest complaint was upper extremity numbness. She did have findings on exam that were consistent with her cord being compressed. Here's her MRI scan. So she's getting compressed pretty severely down there at C6-7. You can see there's loss of CSF around the cord. A bit of a bulge at 5-6. So in her case, we did a 2-level artificial disc replacement. So it's not very common we do those for for myelopathy, but occasionally we'll see that. A few more examples. So this is a 56-year-old guy who works at a power plant. Big guy. You see his BMI is 40.8. Biggest problem is his hands just weren't, he lost his dexterity for working at the control board. He also had quite a bit of weakness from a C5 nerve root impingement. His exam was consistent with myelopathy. So here's his x-rays, and he's got that classic 5-6, 6-7 kind of compressed down and almost fused together, and then has the listhesis at 3-4 and 4-5. Here's his MRI scan. So he's getting compressed pretty severely at that 4-5 level, but he had a lot of foraminal narrowing at the other levels as well. Here's the CT scan. And the CT scan is helpful in this guy. You can see he has that kind of that dark line at that 4-5 disc. It's called a vacuum phenomena, just indicating that there's some instability. And then off to that middle slide, you can see his facet joints are just very arthritic. So in his case, we chose to do an anterior cervical discectomy infusion. So we went in, trimmed off the bone spurs, opened up the neural foramen, put those spacers in, and a big plate up front. Here's a more complicated case. This is a 68-year-old female, rheumatoid arthritis, been on chronic prednisone use, presented with balance issues, upper extremity numbness. You can see she's quite thin with her BMI there. Her DEXA score and her lumbar spine wasn't great, but she'd been treated with Forteo and Prolia in the past. And here's her x-rays. So she's just got that terrible neck forward position, multi-level subluxation. It's a flexion extension view. I mean, she's not horribly unstable, but that listhesis at several of those levels increases a little bit. CT scan showing the listhesis again, and our MRI scan showing her cords getting pretty severely compressed at multiple levels. So this is a surgery we did on her front and back. So down lower, I don't know if you can see that. So we took out the 5th and 6th vertebra, basically, put a long strut graft in there. We didn't have a plate that would reach all the way from C3 down to T1, so we put a kind of a standalone thing up top, and then went from the back and did a fusion from C2 down to T3. So if you guys can see that over there. And we're all happy with ourselves, how the alignment looked in the surgery. She had a really rough go of it after surgery. She had a lot of problems with swallowing. But she came into the office at 2 weeks post-op, and you can see she had developed down at, oops, sorry, the wrong button. But yeah, I can show on this one too. But she developed a little bit of a compression fracture at T3, and you thought, well, I did a big surgery, maybe I should have done more, but at any rate, 6 weeks out, she had gotten a little bit worse, and I advised her she needed to have another operation, but she wanted nothing to do with that. And she gets 5 months out and is really bent forward, a lot of upper back and neck pain. And so in her case, we had to do an osteotomy at T3, so we basically took a wedge out of that 3rd vertebra and then extended her fusion down. We say that white stuff is bone cement we put at each of those levels. So, and I wouldn't say she's terribly happy now. She has good neurologic function, but her neck is obviously very stiff, and she has a lot of pressure and sensation up there, but it was a tough problem. Quick word on a laminaplasty. So some patients we can go in and actually just open up the lamina without completely removing it. So this is a 64-year-old gentleman, kind of the same situation as that first person. He came in to see us with back pain, but on his exam he had signs of myelopathy. His MRI scan showed multiple areas of spinal cord compression. His K-line looked like that most of that compression was pretty far forward. And so with the laminaplasty, we can basically go in and make a cut, a partial cut on the one side of the lamina, a full thickness cut on the other, and then put a bone graft spacer and a plate in there to basically increase the volume of the spinal canal. And then we put those, this is an x-ray post-op, so it's got those plates that span from the lateral mass over to the lamina to open up that canal. So quick take-home points. First of all, just, you see these folks, keep a high suspicion. So if they're having balance problems, do the quick exam. It only takes a few minutes. Usually we watch people walk anyway when we're seeing them for their back, so just have them do that tandem gait. Check the reflexes. You can do a Hoffman's. X-ray wise, check the flexion extension views if there's any subluxation. And don't be afraid to order the MRI scan. I mean, it's better to catch that, have a few negative MRIs rather than letting someone go around that's got spinal cord compression. Whether or not they're going to get worse, it's hard to say, but if there's any questions, we're more than happy to see them. So, okay, this is the funny video. You got to watch this guy. This is about how to refer to patient.
Wow, I can see again. Thank you very much.
Next.
Hi. So, when I go like this, it aches a bit there.
Right.
And I just thought, I should get it checked out.
I can't. It's
my friend had the same thing.
Okay.
Yeah, and he's dead.
Okay, so normally people have a diagnosis before they.
Yeah, but my doctor said just to come to you.
Okay, so he shouldn't have said that.
This is she actually.
Sorry, she.
She said just to get you to fix everything, just cover all bases.
But I need to know the specific problem.
But can't you just do my whole body?
No.
Or maybe just the top half?
No.
Ugh, a waste of an afternoon.
Next.
Any questions? You can send us the stuff that you don't think is appropriate. I was just joking with that one. At any rate. All right.